Good morning, good afternoon, colleagues. It's 11:30 a.m. India Standard Time. Please allow us 1 more minute as many colleagues are still joining, and then we will start. Thank you. While waiting, I already see some questions. This webinar will be recorded. And then we would like to share only if we can get permission from the speakers. So we will keep you updated. Thank you for your question. Okay, good morning, good afternoon, colleagues. Let's get started. Our webinar on Nipah virus infections, hosted by Community of Practice of Public Health Intelligence in WHO Southeast Asia region and Health Emergencies Programme at the WHO SEARO. Thank you so much for joining. My name is Masaya Kato, Program Area Manager for Surveillance and Alert Team in WHO Health Emergencies Programme, WHO SEARO. Dr. Pushpa, would you like to introduce?
Very good morning, colleagues. I am Dr. Pushpa Ranjan Vijayasinghe, Program Area Manager for Pandemic and Epidemic Management. And in addition to that, I do represent our Regional Emergency Director also in this webinar because he is unable to join due to a conflicting activity. Back to you, Dr. Masaya. Thank you very much.
Okay, so we received so many colleagues for registrations. So we decided to also open YouTube. So in case if any of your colleagues cannot join this Zoom link, please share this information. You can access this WHO Southeast Asia on YouTube, and then you can see the streaming of this webinar at the same time. Okay, let's go to the next slide. Just please allow us one slide to introduce our community of practice. We initiated last month, August 2025, of a regional community of practice for public health intelligence, PHI, in the Southeast Asia region, with a mission of creating platform for continuous learning and collaboration on public health intelligence, as well as epidemic intelligence from open sources to strengthen preparedness for public health threats. We have members who are offshore professionals and partners involved in public health intelligence, including One Health stakeholders in our region. If anybody would like to participate, please contact our WHO country offices for participations. We try to share knowledge, updates, and advancement, and try to drive innovation in public health intelligence activities in the regions. We conduct technical webinars every 2 months, and the subject of the webinar today is Nipah virus infections. Next slide. So today's webinar agenda. We have speakers from experts from India, as well as WHO SEARO. So we have the 2 speakers from West Bengal, and then where we had recently 2 cases of Nipah virus infections, followed by a colleague from Kerala, and then the experts from the National Institute of Virology, Pune, to talk about the laboratory matters. This will be followed by Dr. Pushpa to speak about strategic approach in managing Nipah virus infections. I will briefly talk about the WHO advice and risk assessment, and then we would like to keep a good amount of time for the moderated discussions. So we would like to invite the first speaker, who is Dr. Dipankar Maj, Director Hospital Administration and Planning from Government of West Bengal. So over to you, Dr. Dipankar.
Thank you, sir. Am I audible?
Yes, loud and clear, please.
Okay, sir. So I would request Dr. Pritam Roy, WHO NTD coordinator, to
Good.
please come to the starting slide. Yes. Sir, are the slides visible, sir?
Yes, we can see it.
Okay. So I will talk about epidemiology and public health response of this particular incident that occurred in January 2006 this year in West Bengal in a particular focus. So next slide, please. The thing started like this. A private hospital in a district town about 25 kilometers away from the state capital, that is the city of Kolkata. A female nurse of that hospital, aged about 25 years, she was transferred in to her own institution on 4th January from another hospital, which is about 100 kilometers away, and that is near her hometown, and she was in unconscious state. She had respiratory insufficiency and was already put on ventilator from that previous hospital. She had prodromal symptoms since 31st December. And she was brought to this her own hospital on 4th January, and she was unconscious. Next slide, please. Another male nurse of the same private hospital, aged again 25 years, was admitted to that very hospital on 4th January for workup of persistent fever with headache and cough. He gradually deteriorated, and on 11th January, he had to be put on mechanical ventilation. Next slide, please. Diagnostic workup was done for acute encephalitis. In both these cases, no organism could be detected. CSF study showed features of viral encephalitis. On MRI of brain, both of them, these two cases, they showed bilateral multiple small acute diffusion restricting lesions consistent with acute influx. This female nurse had a history of visit to a village in Nadia district close to the border with Bangladesh. We know that Bangladesh is a country endemic for Nipah. So the neurologist of that private hospital sensed something and called an infectious disease specialist of All India Institute of Medical Sciences, Kalyani, for a consultation. Next slide. This doctor from AIIMS, he is the person who took samples from both these cases on 11 January, tested them in his own lab, and found both of them to be positive for Nipah on RT-PCR. He notified this incident to the central government level in the late evening of 11 January. From there, information came to the Principal Secretary of State Health Department, West Bengal, and the alarm was pressed. That was late evening, 11 January. Next. So you can see the map. Top in the north, there is 1 star, and also in Nadia district, there is 1 star. This indicates past 2 incidents of Nipah in West Bengal. The north side was in 2001, and in Nadia district, it was in 2007. Now, in the current incident, you can see 2 legends, one in North 24 Parganas, south down, and also in Purva Bardhaman. Purva Bardhaman is the district where this female nurse, he first attended in a hospital, and from there she was brought to the hospital in North 24 Parganas, where he is actually she herself is a staff. Okay, next slide. So these two patients were immediately isolated with their own hospital. The village in Nadia that was visited by the female nurse was suspected as the source place of infection. The two nurses, one male nurse and one female nurse, they had overlap of duty hours on 19th to 21st December. So the female nurse who visited that Nadia village was considered as the primary case and her male colleague as the secondary case. However, there were doubts about it. We will later come to this aspect again. Thank you. Next, please. So from 12th January morning itself, contact tracing exercise was started within and outside the hospital. The young lady had history of movement to different places after initiation of her symptoms, to a professional examination center in Bardhaman district, to her hometown in that Purva Bardhaman, and she also had made visits at one local doctor and two other hospitals at or near her hometown. But the male nurse had only local movements, not beyond. Next. A National Joint Outbreak Response Team, NJORT, was formed by the central government. The members of this team reached Kolkata right by the morning of 13th January. National Institute of Virology, Pune, was also pressed into action. Confirmation of lab diagnosis came from this very center. The NJORT and the rapid response teams from these two districts, North 24 Parganas, that is the focus district, and Purva Bardhaman, the home district of the lady, the rapid response teams of these two districts and NJORT, they worked in convergence, and detailed route map of movement of these two cases was chalked out. Next. So the summary of contact tracing is, we issued a fresh guideline. Although there were national level guidelines, we issued a fresh guideline to make everything clear about the definition of high and low risk contacts and their follow-up actions. By 15 January, this line listing of the contacts was complete. A total of 174 contacts, 48 of them high risk and rest 126 low risk were listed. 26 of them were very close contacts, and some of them also had some mild symptoms. So they were put into institutional quarantine. The rest were sent to home quarantine and were followed up telephonically twice a day. Next. Samples were collected from all these contacts. From initially, these samples were tested in AIIMS Kalyani, but from 15 January onwards, the mobile BSL-3 lab that was sent from NIV, it was rushed to Kolkata, it performed the tests. Ribavirin was given to the high-risk contacts. Artificial results of all the contacts came negative. Contacts were tracked till 21 days from the last possible exposure, and that date was, the last date was 1st February. Those who had initial some mild upper respiratory tract infection symptoms soon were symptomless. Next. The male nurse could have contact with the female nurse during 91 to 21st January, till when the nurse didn't have any symptoms, the primary case. So we had doubts whether really this lady who was suspected as the primary case was really the primary case. So we kept on investigating. Through search of the records of the private hospital, another case was revealed from a suburban town not very far. A lady of 55 years who had fever, diarrhea, dizziness, and developed pneumonia and ARDS with AES died in that same hospital on 22nd December. She had history of consumption of raw date palm sap 16 to 17 days back, and also had history of handling fruits in her own household fruit garden. Both these two Nipah positive cases, this male and female nurse, they attended to this patient very closely during 21 to 22nd January. So perhaps this lady, the lady 55 years lady, perhaps she was the primary case. Next. So a few words about the course of these confirmed cases, the male nurse has already recovered. 2 sets of samples were tested negative on RT-PCR, and he was sent home on 30th January. But the female nurse, unfortunately, though came out of the ventilator, is still unconscious. GCS score has improved only a little. She is still positive on RT-PCR till 31st January. So altogether, we had only 2 cases of Nipah in this incident. Some loosely suspected cases reported from different other hospitals all proved to be negative on lab test by the NIV team. Next. So the positive aspects of this exercise. The National Joint Response Team, National Institute of Virology, AIIMS Kalyani, WHO NTD, state and district health teams, and the private hospital, all they have worked in close coordination. Synchronization among the concerned branches of the state health department. State drugstore procured the antivirals in war footing. Specific guidelines were issued with the help of WHO NTD that helped the personnel down the line to act in a specific way. Control room was opened at the state headquarters to address public concerns. Next. So the challenges were, what we faced is, out of concern, many people, they unnecessarily requested for tests. We had to face these situations and we had to tackle accordingly. A big lot of healthcare providers, if they were put into quarantine, could put the hospital in trouble. So very judiciously, we allowed low-risk contacts to continue with their work, but with protective barriers on. Now the message that do not take raw date palm sap, this could have harmed the molasses industry. The molasses are prepared from the date palm sap. So that could have harmed the industry, but we had to put some restraint, and we have to assure people that the molasses is processed thing. It is exposed to heat, so it doesn't have any risk factor. Okay, next. So at the end, what I like to say is, in the 2007 incident in Nadia district, we had 5 cases, all of them died. But this time, we had only 2 cases. The transmission could be fortunately halted at the very focal point. No other case cropped up. And State Health Department is now in the process of developing a further action plan for systematic surveillance and any further emergency situation. So this is from my side.
Dr. Dipankar Maj, thank you very much for very informative presentations. This was really giving us an overview of recent Nipah cases in West Bengal. Thank you so much. And for the colleagues who have a question, could you please put in this Q&A box rather than chat box? We will try to manage your question as much as possible at the later stage so that speakers can respond. So please allow us to move to the second speaker, Dr. Yogiraj Rai from Institute of Postgraduate Medical Education and Research in Kolkata, West Bengal, who can also share with us information about recent cases in West Bengal. Over to Dr. Yogiraj.
Thank you. Very good morning. Can I have the slide, Dr. Roy? So this Nipah cases, we got 2 cases. There is clustering of encephalitis cases along with desaturation of their clinical presentation. These are the usual presentation in both the cases, and both are temporally related. So this kind of presentation, actually, next slide. Actually, next slide, please. Actually, there are 2 nurses in Narayana Hospital in a suburb of Kolkata. The place is known as Barasat. presented similarly with cases happening one after another. The neurologist and the critical care expert discussed both cases as their initial workup was negative for usual investigations for acute encephalitis syndrome and also for causes of ARDS. The infectious disease expert, they called from nearby All India Institute of Medical Science that is situated in Kolani, 30 kilometers from that place, and discussed the case with them. He personally seen the cases on 11th of January this year. So this was first ID expert roped in on 11th of January. Next slide. So what he saw, there is a history of fever. There are two cases. One is male nurse, one other one is female nurse. The female nurse was presented a bit earlier with a fever for 6 days, followed by sudden unconsciousness with advent of frequent generalized tonic-clonic seizures that was going on with along with unconscious situation. He was traveling to there is a medical college where his parents took the lady to that medical college in the emergency. The emergency people of that medical college decided that the nurse should be admitted under intensive care unit. On 4th of January, as she rushed to that emergency, she was transferred to intensive care unit. There was rapidly deteriorating acute respiratory distress syndrome requiring intubation and mechanical ventilation, and multiple anti-epileptics are required to control her seizures. The usual acute topical fever workup like malaria, dengue, scrub, lepto, these are usually common causes of acute febrile illness along with sudden desaturation and also encephalitis in our area. The workup was totally negative, and they immediately decided, as there was common rapid diagnostic tests are negative, to go for a lumbar puncture, and it was undertaken immediately. Next slide. The lumbar puncture revealed cells around 80 with 90% lymphocytes and protein just elevated around 101 with CSF gram stain, ZN stain, TB gene expert negative, and patient was put on injection acyclovir, ceftriaxone and vancomycin, thinking that this could be a acute encephalitis syndrome and possibility of meningitis cannot be ruled out in an acute setting. So they put on acyclovir, ceftriaxone and vancomycin. So after 2 days, there was no improvement. So the family person decided to shift her to her own hospital at Barasat, where she works in an intensive care unit also as a staff nurse. So they decided to shift her on 6th January. They admitted her to this Narayana Super Specialty Hospital at Barasat. There was no improvement over next few days, and on the 6 days of illness, the Glasgow Coma Scale was 3/50. There was a history. As the patient is totally unconscious, she cannot give the history. Her parents has given history that she went to a village in Indo-Bangladesh border to attend a marriage ceremony. 2 days. For 2 days, she stayed there, and it was 15 days prior to onset of symptom. Next slide. Next slide. So if we think about the another one case, the male nurse was febrile with chills and headache for 9 days. He was suffering for fever, and he was doing his duty taking paracetamol. He was doing his usual duties also. Admitted in Narayana Hospital due to non-responding fever for 9 days on 4th of January. So both of the patients got admission on 4th of January, one in a medical college, another one at their parent hospital at Narayana Super Specialty Hospital. Subsequently, over next 4 days, nausea, vomiting was persistent and what was not responding to usual antiemetic. And on 8th of January, that is after 4 days of admission, patient started to have agitation, restlessness, and talking very irrelevantly with few hours of irrelevant talks. Suddenly, there was desaturation. Over next 2 days, multiple generalized tonic-clonic seizures happened, and which ultimately led to deep coma during requiring intubation with a mechanical ventilation. But the desaturation was not very high grade, so his airway is maintained by the endotracheal intubation with a FiO2 of 30%. They were able to maintain his saturation. And all acute febrile illness workup was negative. Influenza PCR was negative. So he also undergone for CSF examination, where multiplex PCR for common bacteria and viruses are negative for our place. CBNet for tuberculosis is also very common. Tuberculosis is very common in West Bengal, and it was found to be negative on CSF workup. The usual presentation in CSF was lymphocytic pleocytosis with elevated protein and persistence of preserved glucose. It was finding the lymphocytic pleocytosis with elevated protein and preserved glucose. Next slide, please. And the MRI, and they both of the patients undergone MRI, and the MRI was very similar in both cases. The female nurse had multiple small acute diffusion restricted lesion of bilateral subcortical and deep cerebral white matter with involvement of these small acute diffusion restrictions in thalamo-capsuloganglionic area, cerebellum, brainstem, and there are dirty sulci with multiple infarcts, small infarcts, numerous punctate hemorrhage with diffuse leptomeningeal enhancement. So there is involvement of different parts of brain with infarct, punctate hemorrhages, and also the leptomeninges, there is diffuse enhancement. In the male nurse, MRI detected multiple small acute diffusion restricted lesions in bilateral cerebral white matter with deep gray nuclei, brainstem, cerebellar hemispheres, and multiple acute infarcts with diffuse leptomeningeal enhancement. So if we consider both of these MRI, both have acute diffusion restricted lesions throughout the brain, but the female nurse had more aggressive lesions involving entire cerebellum, where the male nurse doesn't have any lesion in the entire cerebellum. There is only in the cerebellar hemisphere, and in there is no involvement of thalamic part in the male nurse. The CT chest was under the male nurse also has been done, and it found bilateral ground glass opacities with bilateral moderate pleural effusion. Next slide. So what has been done on Sunday, 11th of January? So the patient was admitted, both patients were isolated in the same intensive care unit cabin, and they found something is going on, because similar MRI picture with similar kind of presentation with seizure, not responding to usual acute encephalitic syndrome management, all tests are negative. The neurologist and intensive care unit expert both decided to discuss with an infectious disease person who's supposed to be my friend, and he roped in from Kollani AIMS. He got a history that the female nurse has given a history of going to Indo-Bangladesh border 15 days before the onset of illness. Both nurses has a common duty already discussed on 20th and 21st December, and given CPR to a dying ARDS patient with a very short course of illness. So that person had ARDS with very short duration of illness, and the person succumbed. So that raised some history of exposure from that patient also. However, as both a patient at Glasgow Coma Scale 3, they don't have given at that time any history of taking raw dead palm sap, which found to be later that both of them probably has taken raw dead palm sap in past 1 month also. Nipah was a differential for Indo-Bangladesh border with acute encephalitis syndrome with desaturation in this combination and not responding to usual treatment, and along with the usual tests are negative. Both the ID expert, the infectious disease expert, along with the neurologist decided that we should test for Nipah at this time. So sample from nasopharyngeal, oropharyngeal swab, urine and blood was taken from the both patients, and sample was transferred to laboratory at AIIMS Kalyani. Next slide. Next slide. In the evening, next slide, please. I got a call from the Department of Health and also from Dr. Shayantan, who was that infectious disease expert from Kalyani AIIMS. And both of the patients were already isolated, and they told us that both of the patients found to be positive. So urine PCR for Nipah, blood PCR, and also the nasopharyngeal swab PCR is positive for Nipah, and there is a certainty that the test is very highly sensitive and specific. So as the presentation, clinical presentation fits with Nipah, we decided that whether we should wait for the test to be done repeatedly in the NIV Pune. Before that, we should start some treatment. Whatever the treatment is available to us, we should start at that time. So at night at 10 a.m., we decided to talk with a person who has supplied us in past with oral ribavirin. So we started oral ribavirin with 2 grams through Ryle's tube at 10 a.m. at night in both patients. We started with initial dose of 2 grams. We tried to get remdesivir. We discussed that with our health department and requested our health department to procure remdesivir as soon as it possible. The team of neurologists, critical care expert and pulmonologists joined hand and working till together till today to see the seizures, the general care, and lung physiotherapy, along with if there is any blockage due to mucosa, the lady nurse required twice clearance of the mucosa, the block from the bronchoscopy. So that was required and was done by pulmonologist. Adequate infection control measures already was under in that department going on. So they use PPE, usual donning and doffing procedures, and fromite measures. So due to experience of COVID, this is still something that is already in our habit, and this was not very difficult to take at that time. Next slide. Next slide. So the all ID infectious disease experts of government of West Bengal sat together along with critical care medicine experts, and we had a consensus and discussed about different experiences of twice experience of West Bengal and also from the literature available along with the Kerala experience, state of Kerala experience, and we decided that till we get the drugs, we continue with ribavirin, initially 2 grams, followed by 1.2 gram daily, twice daily for next 9 days. whenever it is available, remdesivir will be started with 200 milligram IV loading followed by 100 milligram IV OD for 9 days, and we tried to get favipiravir also. And we decided that we should go up to that place regularly till all ID issues are over and follow up the patients regularly. Next slide. Next slide. So what is the course? We got remdesivir after 3 days, and when the remdesivir initiated, at that time the male patient started moving his limbs spontaneously. So whether the effect was already started due to oral ribavirin, we are not very sure, but that is the time when we initiated remdesivir, the male patient started moving limbs spontaneously. After 3 days of remdesivir, the male patient was responding to command, and both ultimately required multiple antibiotics for episodes of ventilator associated pneumonia, and also the lady required inotrope as she had one episode of shock. As the lady was not responding, the airway support was required, and the lady was not responding rapidly. We decided early tracheostomy probably is required, and the critical care expert has undergone tracheostomy, percutaneous tracheostomy in that patient early. Subsequently, ventilator-associated pneumonia was managed, cured. Both of the patients were off inotropes, off ventilator, and subsequently both RT-PCR negative on an interval of 10 to 15 days from the diagnosis. So we had done all 3 sets of nasopharyngeal swab, urine, and blood PCR, and both are negative. So next slide, please. Next slide. The current status: the male nurse is discharged home with normal physical function, with few incoherent talks, and he will be on neurological follow-up in future, and hopefully the incoherent talks will respond also. The female nurse is our real concern. She is RT-PCR negative, tracheostomized. She doesn't need any oxygen support. Only the general airway care of the tracheostomy is required. General supportive care is required, and her Glasgow Coma Scale is improved from 3 to 5, but there is not much improvement after that. She is still at the hospital along with her colleagues, and they are taking lot of care of her. No health worker or contact tested positive till now or symptomatic for typical Nipah-like illness. Next slide. So what are the lessons that we learned? That early diagnosis and best supportive care is key for that patient. Early initiation of available antiviral, whatever the antiviral, the usual amongst the usual 3 antivirals, whatever is available, give that early. Adequate management of secondary infections and seizures is key, because patient will be on ventilator and will high possibility that he or she will develop ventilator associated pneumonia or intensive care unit related infections. And seizure control is also utmost important. Starting remdesivir early is probably important finding also, but probably we should not discard the good old cheap ribavirin that we continued for. So we have given remdesivir and ribavirin both for 9 days in this patient, and there is no hemolysis, there was no LFT derangement or acute kidney injury in these 2 patients. HIC measures, hospital infection control, is still COVID experience is helping us, as everyone was on toes for that, and please bring your best intensive care unit in the team. That here we got Dr. Pal and Dr. Dasgupta, both helped us a lot, and Dr. Pal is still managing the female nurse, and hopefully he will be able to send her home. Thank you.
Dr. Yogiraj, thank you so much. Again, very informative presentation on clinical history, clinical management. We are very, very grateful for your presentations. If your time allows, please stay with us. For later, we may come back to you for more questions. Thank you so much.
Okay, sir.
So we have an honor to, we have an honor to invite the third speaker, Professor Anish. Is a professor and nodal officer of Kerala One Health Center for Nipah Research and Resilience from Kerala State of India. Over to Professor Anish.
Yeah, good morning. I am very thankful for the WHO team for this opportunity. So I will just switch off my video because I want to save some bandwidth. I will share my slides. Okay, I think I am audible. Okay. Specifically, I am discussing the Nipah encephalitis learning from Kerala that might have used in West Bengal also. So we had 10 episodes of Nipah spillovers from 2018. And out of that 10 episodes, 2 turned to be outbreaks. That means there were human-to-human cases in 2 exposures, that is in 2018 and 2023. Other 8, out of 10, 8 were ended up in single cases. That means 80% of spillovers reported in Kerala ended up in only 1 case. Only 20% ended up in multiple cases, that is human-to-human spread. So this is the same experience from Bangladesh, that most of the Nipah cases will be ended up in single cases. But there could be human-to-human transmission, especially in families as well as in hospitals. So this is basically why Nipah is very important. I am not going to discuss this particular slide because lack of time. I will just go directly to the lessons that we have learned from Kerala. So this particular paper, we are discussing the basic lessons that we have learned. Maybe some recent findings are also there that I will try to incorporate in this particular discussion. So anyway, if you can go through this paper, you can go through many findings that we have made in Kerala. So one of the major findings that we have got that echoes the same thing from Malaysia and Bangladesh, that destroying bad habitats or scaring them with noise triggers migration and maybe increases human-bat interaction, paradoxically raises the risk of Nipah virus spillovers. If you try to get rid of them, maybe artificially, by cutting trees and all, we are experiencing a chance of outbreak in those places. That is our experience with Kerala. Wherever there is outbreaks in Kerala, there are natural destruction of especially bad roots. And the Nipah fear will trigger this kind of a social this reaction. That is also very important. Whenever there is number of Nipah cases are increased in community, we have to take care that we have to tell people that do not disturb the bats, because disturbing bats will increase the possibility of spillovers. And second lesson that we have learned, active AES, that is acute surveillance, acute encephalitis syndrome surveillance, and using PCR or NAT-based diagnosis will save lives and contain Nipah outbreaks. That is very important thing. And NIV is and with the Dr. Pragya Yadav and team is helping us a lot. One is, if you are able to identify the primary case itself, you can save life. Even primary case could be treated and cured if you are able to find the primary case. In the last 4 episodes in Kerala, 2 were saved, who are living. Even the primary case is living. And second advantage of AES surveillance is you can give chemoprophylaxis for high-risk contacts and you can save them. the dosages and all, which is already discussed by the previous speaker. And third one is, if you are able to find out who are exposed or who are having the disease, definitely you can contain the outbreak by getting them in quarantine and isolation. So the active AES and ARDS, that is acute respiratory distress syndrome, these syndromes should be in surveillance in countries where there is Nipah outbreak is possible. Yeah, that include maybe the whole Southeast Asian region. So that is very, very important thing that we have found from our experience. And this is about the dosages of remdesivir. So remdesivir is a wonder drug for Nipah. That is our experience. Kerala is using remdesivir for last 3 years. And we can just see this table. And out of the 5 people who received remdesivir, 0 mortality. And out of the 2 people who received monoclonal antibody, there is 0 mortality. If you are able to identify the patient early, treat them with remdesivir and monoclonal antibodies, you can just reduce the case fatality to a larger extent. Ribavirin is also helpful, especially for if the patient is a child or something like that. But remdesivir and monoclonal antibodies are wonder drugs in Nipah. That is the major finding that we have got from Kerala. And third learning point is the hospital-based super spreading. Nipah, if maybe many people who is hearing this lecture or the discussion may be knowing that Nipah won't transmit to others in the early part of the disease. When the disease is advanced, when the person suffering from the disease is clinically very ill, then only the transmission will start. So most of the occasions, the outbreaks are happening either in families or in hospital. Most of the times it is from hospitals. So a hospital-based super spreading is very likely in Nipah. So often it happens in emergency department or when the patient is going for some investigation. So these areas, the healthcare providers could be affected by the disease. Sometimes the other patients and bystanders could be affected by the disease. What you are seeing in the picture is the 2018 Nipah outbreak of Calicut, Kerala. And you can see that the Nipah is how this is transmitting from one person to another. The left-hand side, you can see a hospital ward. And in the middle, you can see a CT room. And in different places in a hospital, a critically ill patient can transmit Nipah. And often, in case of many other disease which has got pandemic potential, the super spreading chances or the probability of super spreading is an engine for Nipah transmission. If you are able to reduce the super spreading from hospital, you can reduce the size of the outbreak to a large extent. Then that is a fourth one, super spreading potential of a non-isolated primary case with respiratory symptom. One thing is super spreading is very often with primary case. It is less likely with secondary and tertiary case. In Bangladesh, we have got experience that super spreading happens from secondary case, but usually super spreading will happen from the primary case. And the symptom of the primary case is important. A purely neuritic syndrome, that is the only AES, acute encephalitis syndrome, the chance of spreading is unlikely. But if the person is presented with ARDS, that is respiratory syndrome, the chance of spreading will be more because the person may be coughing and the infectious agent may be going to the air. So that is a very important thing. So in the table, you can see that the spreading is happening from primary cases. The reproduction number, effective reproduction number is 2.5. In 2018, we have got an experience that the reproduction number was as high as 20. And in isolated case or in a non-isolated case also, you can see that the reproduction number is very high. So two factors are very important, that a primary case with respiratory symptom and primary case with respiratory syndrome who is not isolated. That is a very high risk of spreading in Nipah. So this is the fourth one. This is after COVID-19, we were having a habit of wearing masks. But if you just look at our hospitals, especially in the hospitals in the global south, you can see that many people, even the healthcare providers, nurses, they are not wearing a mask. When you are dealing with a patient with acute encephalitis syndrome or acute respiratory distress syndrome, The masking a wear is something like you are saving your own life. So in our hospital, we noticed that many people, the bystanders, other patients, and the nurses who are not wearing a mask, and not wearing a mask is a risk. But one good thing is we are not seeing that everybody coming in contact with another Nipah patient is contracting the disease. Some people are getting the disease and some people are not getting the disease. So that is a very interesting thing, because what is happening? What is the personal susceptibility for this particular disease? Sometimes it may be something related to the receptor of the virus, that is heparin B2, B3 receptor. The morphology of that receptor may be different in different kind of people. So it is very important to study. Now we are mounting a study with Institute of Advanced Virology, Trivandrum, to study the morphological differences of heparin B2 and B3 receptors among human population, how much these particular differences are contributing to susceptibility of infection. That is a very important thing. So this I have already discussed, that wearing a mask or any kind of a barrier precaution will help you to reduce the chance of infection. In no healthcare workers in history of Nipah who were wearing a mask at the time of maybe treating or caring the patient contracted Nipah. At this point of time, it is not an airborne infection. This may be a droplet infection, may be transmitted through contacts or maybe close proximities. So definitely a 3-layer mask will help you to save your life. Whenever you are seeing a patient or with an AES or ARDS, definitely it is very important to wear a mask. That is the 6th learning point that we have got. And this is, Nipah is a seasonal disease. And you can see that in Kerala, Nipah is in monsoon, summer seasons, and it is the peak fruiting season of Kerala that start with maybe April and it end by maybe September. In right-hand side, you can see a study conducted by National Institute of Virology, and they demonstrated that from February, the seroprevalence of bat roosts are increasing, and even the virological positivity is also increasing. So in Bengal also, if you are able to study, you may see that there is a pattern in infecting the bat roost. In Bangladesh, the high-risk period starts with October and it ends by March. So it may be Bengal, maybe as it is close to Bangladesh, and winter may be more prone season for Nipah virus. And the 8th learning point is not only the throat swabs. If you just look at the bats, you can see the rectal swabs are positive. The internal organs are positive for the virus. That means you can infect it from the bat by its fecal matter. You can infect it by its urine. If you have got a habit of killing bats, even you can get infected by the body secretions. If another animal is eating bat, just like cats, can also act as an intermediate host. That is a very important thing, that many animals, as B2, B3, heparin B2, B3 receptors are evolutionary conserved. Many animals can act as an intermediate host. Even rodents can act as intermediate host, not only the pigs and horses that we already know. Many animals can act as an intermediate host. Whenever there is a Nipah outbreak, you have to think about the possibility of the intermediate host. Again, we are conducting many studies to check, because in Kerala there is not much pigs and we do not have that much horses. We do not have date palms, but still we have got cases. So we are checking whether the domestic animals can act as intermediate host. This is very important thing, that Nipah could be transmitted by different ways. In Kerala, we were not succeeded in testing maybe the fruits, date palm sap or toddy or what the beverages and fruits, but we were consistently finding the bat roosts are positive. So the bat roost surveillance is very important. Maybe in Nipah unaffected area also, bat roost surveillance could be mandated, and we can just check whether the bats are already infected and what is the likelihood of human infections. That may be a good thing. Other than the Nipah affected countries, I think Thailand has studied this positivity of Nipah in bats. And recently, I think Sri Lanka has also got that kind of an inference that their bats are infected. If you look at India, according to NIV study, you can see that the entire India is infected. the infection in bats is very common, but only few sites are reporting human cases of Nipah, maybe because of the strengths in AES and ARDS surveillance. This is my last point. Definitely, Nipah is a disease, the non-health disease. You have to get the help of the virologist. Virologists are coming from NIV, and we have to get the help of animal husbandry people, forest people. We want to get the very, very strong health system for the surveillance. The testing should be, it is always better to go for a molecular testing rather than an antibody assessment, because a molecular testing will save lives. So it's very different things are there. Teams has to be constituted. And I suggest maybe in Kerala, based on the Kerala experiences, we can align all the intervention maybe in 5 domains. One is surveillance, contact tracing, and quarantine. Second one is the health system strengthening, especially to identify cases and manage cases, diagnosis and management of cases, and newer drugs, just like remdesivir is actually for promising result. A vaccine is in the pipeline. It is just like Covishield, that is this chimpanzee adenovirus vector vaccine is available. It's actually able to be available in preventing Nipah virus. That is also a promising thing, and a lot of research should be happened. And you know that it is out of one of the 10 diseases that is WHO is calling for R&D in the context of pandemic preparedness. And the information, education, and communication is very important. You have to go to the community and tell them how can themselves they can prevent maybe from diseases, as well as if there is a disease, how they can report cases of AES and ARD. These are my slides, and thank you again. Thanks again for the opportunity.
Professor Anish, thank you so much. Kerala has a vast experience of managing Nipah virus outbreak. Since 2018, Kerala has managed multiple outbreaks, and then your experience, insights based on these past outbreaks are really precious. Thank you very much. Again, if your time allows, please stay with us. Later, we may come back to you with a few questions. Please allow us to proceed to the next speaker, who I have the honor to invite Dr. Pushpa, who is going to talk about our regional strategy on Nipah virus infections. Over to Dr. Pushpa.
Thank you, Dr. Masaya, and greetings, colleagues from Delhi once again. And I think Dr. Pradya's and Dr. Anish's presentation will make it's easier to explain the strategic approach for prevention and control of Nipah in WHO Southeast Asia region. Next slide. Next slide. Colleagues, Nipah virus is a high-impact infectious hazard with pandemic potential. It has been listed as a priority pathogen under the WHO's R&D blueprint, that means research and development blueprint for epidemics since 2016. Nipah virus has a wide geographical range starting from South Pacific along the Western and Northern Australia, and then Southeast Asia, South Asia, up to Madagascar. It can infect multiple animal species and shows a strong propensity for spillover, as we heard, from animals to human populations. Human infection is associated with severe clinical disease, high morbidity, and extremely high case fatality ratio and long-term neurological sequelae. Early detection and effective infection prevention and control measures are critical to prevent rapid escalation and widespread. Medical countermeasures, as we heard, remain limited, with most options still unlicensed and in early or mid stage of development or in the pipeline of development. Taken together, these factors underscore WHO's classification of Nipah virus as a priority pathogen for preparedness and accelerated research and development. Next slide, please. Nipah virus was first detected in our region in 2001 in India, And in the same year in Bangladesh, with outbreaks occurring almost every year except for previous in Bangladesh. Following the 2018 outbreak in Kerala, WHO SEARO convened an expert consultation in October 2019, just before the COVID, to assess regional risks and guide priority actions. Experts provided recommendations across 10 thematic areas. You heard most of them, 10 thematic areas, and requested SEARO to develop a structured regional strategy to support member states in preventing and controlling Nipah virus disease. Next slide, please. The expert consultation highlighted several important regional challenges. First, there is a clear potential for Nipah virus disease to emerge in new geographic areas within the region. Potential is there. Second, estimating both the likelihood and impact of spillover events from animals to human, as well as the potential for further spread within countries, remain inherently complex and uncertain. We heard from speakers. In addition, significant gaps persist in policy and strategic coordination across the human, animal, and wildlife sectors. Overall, at that time, One Health coordination capacities were assessed as suboptimal, limiting effective multi-sectoral preparedness and response. Challenges related to risk communication and community engagement continue to exist, and as we heard, including in communities with prior experience in managing multiple health risks, including Nipah. Next slide, please. Significant evidence gaps remain in understanding the factors that drive spillovers from wildlife to humans, as well as subsequent human-to-human transmission. At the farm levels, biosecurity practices are often inadequate, creating the risk of amplification and spread following a spillover event. Surveillance systems for both human and animal health remain limited, particularly in at-risk countries with ecological suitability for Nipah virus transmission, but having no reported cases. Diagnostic capacity is insufficient, constrained by limited laboratory infrastructure, weak lab networks, and restricted access to Nipah-specific diagnostics. In addition, as we heard, medical countermeasures face multiple barriers, including regulatory challenges across product development, availability, and use. Finally, broader health system challenges persist, including gaps in clinical management, infection prevention and control, and the ability of health system to recover and build resilience following outbreaks. Next slide, please. So the regional strategy sets a clear vision to prevent illness and deaths due to Nipah virus infections in human population across the Southeast Asia region by 2030. It is guided by several key principles. Nipah virus is an emerging priority zoonotic pathogen associated with severe disease and high mortality. Yes. However, countries in the region are not at equal risk. Countries are not at equal risk, and even within big countries, all the places are not at equal risk. And the strategy therefore allows for risk-based prioritization. The approach is flexible, with the ability to incorporate Nipah viruses with other Nipah viruses as potential hazards. Now, this is explained. If you read the Emerging Infectious Disease December volume, the Bangladesh colleagues have already published detection of bat reovirus among a Nipah negative patient who manifested with Nipah-like symptoms. So our strategy provides that flexibility. It follows a One Health approach, as we heard, to reduce spillover to domestic animals, transmission to humans, and human-to-human spread. Importantly, the strategy leverages capacities built during the COVID-19 pandemic. We heard again, recognizing that investments in Nipah preparedness can also strengthen health system more broadly and in general. However, effective implementation will require strong political commitment and sustainable financing at the country level. We are in a different landscape of funding. We'll go to the other slide, please. The regional strategy is well aligned with existing regional frameworks on health security and health system resilience for emergencies. It adopts a multi-sectoral, multidisciplinary, and risk-based approach with an overarching emphasis on alignment with One Health plans and recommendations. Given the epidemic and pandemic potential of Nipah virus, the strategy follows the full emergency response continuum. So it has preparedness, prevention, detection, response, recovery, and resilience components in operationalization. In addition, it provides region-wide guidance on governance, financing, monitoring and evaluation, supporting consistent and coordinated implementation across the Southeast Asia region. Let's go to the next slide. Now, based on the identified challenges and the recommendations of the expert panel, the strategy does focus on several key components. You heard most of them. First, it prioritizes strengthening policy, strategic, and regulatory capacity. It also calls for enhanced multi-sectoral and One Health system readiness, particularly for early detection, warning, and response to cases and outbreaks. The strategy further emphasizes improving understanding of the socio-ecological drivers of Nipah virus transmission and disease dynamics. Professor Anish tried to summarize few in a nutshell, but there is a long way to go. From a detection perspective, it focuses on strengthening surveillance and information sharing across sectors to enable earlier signals, faster risk assessment, and more coordinated action. Let's go to the next slide. From a prevention perspective, the strategy promotes behavioral change to reduce risks, strengthens risk communication and community engagement to minimize spillover and transmission, and enhances biosecurity measures to control disease in domestic animals. To mitigate risk among patients, the strategy emphasizes the development and improved access to medical countermeasures alongside strengthening clinical diagnosis and case management capacity, including infection prevention and control. Finally, it underscores the importance of health system recovery and resilience, ensuring that systems can absorb shocks, recover effectively, and be better prepared for future outbreaks. Next slide, please. In summary, the regional strategy sets out the rationale and context for a well-integrated approach to combating Nipah virus infection in the WHO Southeast Asia region, and it has the flexibility to incorporate other high-threat pathogens also. It supports improved preparedness of member states to prevent illness and deaths due to Nipah virus infection, while also strengthening overall regional capacity to prevent and respond to zoonotic disease outbreaks. The strategy calls for implementation guided by two key principles. First, One Health-based risk assessment aligned with national frameworks, and second, country categorization based on reported Nipah cases. We have two types of categories, Category A and Category B countries in the region. Let's move on to the next slide. This is my last slide. In conclusion, I would like to sincerely thank all those who contributed to develop the regional strategy for Nipah and other Nipah viruses. But here today, I would like to take this opportunity to thank two individuals who are in this audience. One is Pragya Yadav, was a part of this expert committee, and right throughout, she reviewed this draft and provided lots of comments. And the other one who is in the audience is Dr. Manish Thakur from WHO Southeast Asia region. He shouldered the whole burden to draft and get this published, and this was endorsed by all the honorable ministers of health in the regional committee held in 2023. With that, let me hand over to my friend and colleague, Dr. Masaya. Thank you very much.
Thank you so much, Dr. Pushpa, for always very energetic, informative presentations. It's already getting to 1 p.m. India time, but please allow us maybe 10 to 12 minutes. Extending this webinar. I have, please allow me maybe 3 minutes to go through a quick key points, and then we try to answer some of the questions posed by participants. Okay, so these are already published in WHO disease outbreak news. So I try to go very quickly, but the current WHO risk assessment regarding this recent Nipah cases in West Bengal, we assess risk for subnational level of West Bengal state as a moderate due to known natural reservoir of fruit bats present with some spillover events demonstrated. However, we consider the risk is low for national, regional, global level. India and West Bengal state has implemented quite strong public health measures, and including surveillance, investigation, IPC, infection prevention and control, and risk communications. There's no reports of cross-border transmissions. However, it is still possible sporadic cases, spillover events might happen based on known reservoir of Nipah virus among fruit bat populations. WHO advice already part of WHO DOM. In the absence of licensed vaccines or therapeutic treatment for this Nipah virus infections, preventing infection in people really relies on raising awareness of risk factors. So reinforcing risk communication messages about the measures to reduce exposure to Nipah virus is really critical. This also applies to the context of mass gathering where attendees come from different countries and may not be familiar with this disease and its mode of transmissions. Case management needs to focus on delivering timely supportive care, supported by effective laboratory system and adequate infection prevention control measures in healthcare facilities. Based on currently available information, WHO does not recommend any travel and/or travel restrictions. Public health educational messages should focus on the points shown in the slide. I do not go into the details as everything is already in disease outbreak news on the WHO website. But I also would like to encourage you to visit WHO disease outbreak news, Nipah pages on WHO SEARO and headquarters. Dr. Pushpa recently created Nipah dedicated page within WHO SEARO, and the URL are shown in this slide. So this is the end of our presentations, but remaining time, let us try to answer the questions posed by participants to the speakers. I see Dr. Pragya on the screen. I know you have to go to the meeting, so please allow us to start with Dr. Pragya. There was one question about you kindly shared with us these surveys among bat populations. Please allow me to proceed to the speakers from West Bengal. There are many questions posed by participants about this potential primary case. 55 years old female Question include, this patient tested for Nipah or not? Whether contact tracing was done for this case? This is about how IPC has been implemented. These are the questions for a 55-year-old female, which might be the index case. But one more question for West Bengal colleagues is these two confirmed cases, when isolation was started. If you have an exact date, that will also be helpful. So may I invite two speakers from West Bengal, Dr. Dipankar and Dr. Yogaraj, please.
Yes, sir. Regarding isolation of these two cases, whenever it was known that they were Nipah positive, on receipt of test report from AIIMS, so that was in late evening of 11 January, they were isolated. As soon as the positive report came, they were isolated.
So may I consider the isolation started on 11th of January?
11th
Thank you very
January
much.
night. Yeah.
Okay. And then would you be able to share with us, you have already shared with us this potential index case, 55-year-old female. Would you be able to address whether testing was done, contact tracing was done? Over to you.
Yes, sir. When we arrived at this suspicion of this case being the primary case, by the time that lady died, so there was no scope or no samples were left also, so that we could trace back and do Nipah test for her samples. And regarding contact tracing, very limited contact tracing was done just within her family and just around. No large-scale contact tracing were required, because by the time we information, already many more than 21 days have passed.
Yeah, understood. Thank you very much. So very clear, because we understood the samples were not tested from the first, this 55-year-old female patient. Thank you very much.
Because that lady died on 22nd December, and we got this news of Nipah on 11th January. So by that time, everything was lost.
Yeah. But it was a really great effort retrospectively identifying this case as a potential index case. So thank you so much for sharing with us this information. Very important information. So now we would like to, is it okay? We would like to invite Dr. Professor Anish from Kerala. There was one question asking, what is the big barriers for villagers to understand implementing preventive measures in the communities? Do you have any response to this question?
Yeah. Before answering this question, I have a comment on the possibility of wastewater surveillance in Nipah. Because that is a very important thing that we are also considering. Because Nipah patient may be admitted in a hospital in the symptomatic phase. Sometimes there may not be transmission at all. So the wastewater surveillance project may be good if there is a hospital-based wastewater surveillance project in Kerala, especially in Calicut, because Calicut witnessed many Nipah outbreaks. In Calcutta, if there is a hospital, we can even implement that in Calcutta. So that is a good possibility. That is one thing. And regarding the villagers' resilience building, the villagers are with us in reporting AEA surveillance. They are there to prevent Nipah, maybe taking care of, just reduce the infection control and all other things. The problem, the hurdle or the challenge that we are facing is the villagers want to get rid of the bats from their vicinity. So they will just cut down the trees. Sometimes they will just disturb bats by crackers, and many things are happening. It is very difficult to convince them that let the bats will around their house, or let it be there in the premises. But it is very difficult to convince. That is a critical challenge that we are facing in building resilience in the community level.
Thank you very much, Professor Alish. This is very, very helpful response and sharing with us your insights. Okay, so I think now probably it's time to wrap up. Actually, we received 226 questions, and it's just not practical to answer one by one those questions. What I would like to do is I would like to work with Dr. Pushpa. Maybe we try to respond those questions as maybe question and answers or fact sheet. Recently, Dr. Pushpa created this Nipah web page. So as much as possible, we will review your questions and we try to answer. Dr. Pushpa, is this okay?
Absolutely. I think, there is a lot of interest and there are colleagues from other regions as well. So they good to have that. So we'll work with within our team, we will work and we'll provide and update the website. Thank you very much. A good suggestion.
Okay. And then we also received many questions. Please share the slides. Please share the video. We will double check with the speakers. And then only if speakers give us permissions, we will try to share publicly. So with this, please allow us to conclude this webinar. We had 3,000 participants participated in this Zoom session, but I believe many more colleagues have participated through the YouTube. So we would like to thank you so much for spending your precious time in participating. But most importantly, we would like to really express gratitude to all speakers for providing very precious information from your experience, from your insights. Really thank you very much to all the speakers. With this, thank you very much. Bye-bye.